الموضوع حقيقة طويل، والدكتور وائل طلب انه يكون في تغيير في طريقة الطرح، بمعنى اخر انه نعمل برزنتيشن وبعدين نعرض فيديو احنا عاملينه ونعرضه للزملاء، واثناء هذا العرض ممكن انه نتناقش بعض الامور التقنية او الفنية. Okay, to start with shoulder instability. In my practice, I always ask question, what to do and when. And this question is more come to my mind when I deal with shoulder instability. And this is why, because decision making is sometimes difficult. We have no in the literature a proper definition of shoulder instability, and there is no consensus. And there is no comprehensive classification system which guide management. And this which makes decision sometimes is difficult. A lot of terms, and this make confusion even in classification and in deciding treatment. So to start with, who the patient who has shoulder instability. And if you review the literature to have a definition, a lot of different definition, many definitions, and it's different perception by different authors and surgeons. And most of these definition goes around two themes, symptoms and translation. When we say symptoms, we mean the patient complain of either pain or discomfort, and translation to have the feeling of looseness or slippage, or the patient feel that the shoulder is coming out, either dislocation or subluxation. So when we consider these two themes, we have to ask question. If the patient has only symptoms, such as pain, does he have instability? And if patient has just a translation and he can show you his subluxation, does he have instability without the presence of symptoms? So by conclusion, I think who has shoulder instability should have both of them, should have symptoms and should have translation. The second point, which classification? And a lot of classification system, maybe 18, I found in one article, and they use different criteria. And of these, the most frequently used are etiology, direction, severity, and frequency. And maybe from this comes the FIT system for classification, which consider these factors, FIT, frequency, etiology, degree, severity, and direction, consider it as the most valid content of these variables in considering classification, which may in the future aid in classification guided treatment. Now, the most widely used principle for classification is that of Thomas and Madsen classification, which classify, initially it was not proposed as classification, but as a guide for treatment at their own institution, but it's mostly used by others, which classify into two groups, TOPS, which mean traumatic unilateral in the presence of pancreas, and most of these patients need surgery. So there is trauma and there is structural defect. And AMBRI, which is atraumatic, multidirectional, usually bilateral, and those patients treated by rehab and sometime if this failed by inferior capsular shift. But the problem with this classification is that it simplifies the AMBRI group because it's very heterogeneous group, so it's oversimplification of a complex, really complex issue. And then Stanmore classification may solve that by proposing the polar system or triangle. And he divided these patients into the first one, which is type 1, which is there is significant history of trauma and usually there is structural defect. And this is equivalent to TOPS by Madsen classification. And the other one, which is the polar 2, in the presence of no trauma or less defined trauma, and there is a structural defect. And this is equivalent to AMBRI, which may respond to rehabilitation and may not respond but need surgery. The other group, which is type 3, and this considers the concept of muscle patterning and muscle recruitment, and which is neglected by Thomas and Madsen. And so this group, when there is problem with muscle patterning, surgery is contraindicated. And here is the point. We have AMBRI, but surgery is contraindicated. So this is very important when you decide to treat instability, because it's really sometimes difficult decision. Now, the pathoanatomy for shoulder instability: capsulolabral lesion, capsular, and bone loss. So capsulolabral, we may have pancart, anterior pancart, posterior pancart, or we may have slab lesion. And capsular injury, either intrasubstance, capsular laxity, or the presence of Hagel lesion, which means a humeral avulsion of glenohumeral ligament, humeral side. And bone loss is also again problem, and it may be in the glenoid, either by large bony pancart or by impaction fracture because of long history of instability and several dislocation. It may be in the humeral head, either Hill-Sachs or reverse Hill-Sachs lesion in case of posterior dislocation. Now, when considering treatment, this is very important, because the problem of non-indicated surgery. Back to Stanmore classification system, which may give guidelines for treatment, for selecting patients for treatment. Let's take Bowler type 1. In Bowler type 1, there is trauma, and there is structural defect, mostly in the form of pancart lesion. So most of these patients are treated by arthroscopic pancart repair. And there are variables to consider when deciding treatment, like the age. The younger, the more chance and risk for recurrent instability. The more frequency, recurrence mean recurrence. Time since injury, there is a paper demonstrating that when you do surgery for a patient who's not complaining and there is a history of dislocation for 2 years, surgery will add nothing. Again, success of non-operative treatment, sports activity and functional need, and patient preference. Now, arthroscopic treatment after first time dislocation. Some colleagues in my practice consider that wrong. It's not wrong. And we have strong or accumulative evidence in the literature that significantly show the success of this surgery to reduce the recurrence rate. So if you don't do surgery, you maybe all in all have a recurrence rate of 4 to 60%, and if you do it, this may decrease to 5 to 17%. And this 5 to 17 is the result of heterogeneous group. That means that maybe other than pancart lesion repair, so this high recurrence rate. So trial in each case, even in this Polar 1, in each case of instability, there is a chance and a reasonable chance to try non-operative treatment. And if there is no ongoing symptoms, patient response, so no need for surgery, but keep in mind and tell the patient that he may have recurrence which can reach to 50 to 60%. Now, arthroscopic surgery in terms of pancart repair has limitations. And one of these limitations, technical limitation, when there is Hagel lesion. Hagel lesion, once there, and you should look for it when you do surgery, arthroscopy, this may cause failure of your procedure, and once you diagnose, you may need to do open repair, or if you expert, it needs highly demanding arthroscopic techniques. The second limitation is when there is a large Hill-Sachs lesion or pond lesion, maybe in form of large Hill-Sachs, and it's now proved that the presence of large Hill-Sachs, which engaging, is a potential cause of failure of pancart repair. So you have to deal with that. So if it's engaging, you may need to do remplissage technique, which is a type of capsulotenodesis of the posterior capsule to the lesion, like this. And the other limitation when you have glenoid defects. So once the glenoid defect is more than 25%, you may have what's called inverted pier. And you can suspect that by history if the patient has recurrent instability, a long history of instability, or has several dislocations. And once you suspect, you can do CT scan before doing surgery, and you can diagnose. And if that's the case, you can treat by letter J.